Leke Amaking. Dr. Amaking, will you be able to share your pre-recorded presentation?
I'll be sharing that. Give me 1 second.
Okay. And will you be sharing the other presentation too from VCX Africa by Dr.
That is correct.
Okay, excellent. Thank you. So then we are good to go.
Hi, I'm Leke Aminking from Health Research Foundation, Cameroon. Thank you for joining this DSI Africa Network event. I will be sharing with you today our project on artificial intelligence assisted echocardiography to facilitate accurate image capture and transmission for congenital heart defects diagnosis in sub-Saharan Africa. There are 5 institutions involved in this project from Cameroon, South Africa, and the United Kingdom. And we have 16 senior investigators comprising engineers, pediatric cardiologists, nurses, and epidemiologists. And of course, the project is funded by the US NIH as part of the DSI Africa initiative. So, congenital anomalies are structural or functional anomalies that occur during pregnancy. And there are multiple causes of congenital anomalies, including medications, infections, environmental factors, genetic factors, and nutritional deficiencies. But different CAs have different causes, and for the majority of CAs, the causes are not known. In terms of diagnosis, this can be done prenatally or postnatally, and this is usually by experts, for example, geneticists and pediatric cardiologists and other specialists. Now, prevention and treatment is possible for the majority of major congenital anomalies of clinical importance. For example, neurotube defect can be prevented by supplementation of folic acid during the first trimester of pregnancy. This is a well-known preventive measure for neurotube defect. Congenital heart defects, which is the focus of our current project, can be treated through surgery, especially if the diagnosis is made early. I just want to call your attention to the Global Birth Defects app, which is an app that was produced by Ulster University as to facilitate accurate coding and description of congenital anomalies for surveillance systems or that are operating in low resource settings. And this app can also be used for teaching and even to facilitate diagnosis in clinical practice. And you can access this in the Play Store and Apple Store. Okay, now to our problem of congenital heart defects. As you may know, congenital anomalies constitute about 10% of all global neonatal deaths annually, and sub-Saharan Africa alone accounts for over 38% of all neonatal deaths globally due to congenital anomalies. Congenital heart defects constitute about a third of all cases of congenital anomalies. And in Africa, the problem of the management of congenital heart defects lies mainly on the problem of lack of echocardiographers and expert pediatric cardiologists, so that there is limited screening, late and misdiagnosis, and of course delayed care, and ultimately poor survival outcomes of babies who are affected. So what can we do to address this problem? We know that in recent times there has been downsizing of or there's been a downsize of large ultrasound devices. They are now available as handheld devices connected, even in some cases, to mobile phones. And so this has made ultrasound devices very available, even in remote areas in low resource settings. So what if we are able to empower non-experts such as nurses, medical doctors, midwives, who serve primary and secondary care facilities where majority of the births occur, to be able to use these mobile ultrasound devices to conduct an echocardiography scan and then capture accurate images, which can then be forwarded to a remote pediatric cardiologist in a tertiary facility for diagnosis confirmation. So our project, the focus of our project is on this first aspect. How can we help the non-expert so that they can conduct this scan and capture these accurate images? Our goal, therefore, is to our primary objective, therefore, is to develop an AI model that will be able to capture the accurate image on the background while the non-expert is maneuvering the probe or moving the probe around the baby's chest. So all the non-expert needs to do is to move the probe around the baby's chest, and then the AI model that we're going to develop will do the job in the background to capture the right images. Of course, to maneuver the probe is a very skilled procedure, and that is why our second main objective is to develop an SOP and an instructional videos that can guide this non-expert on the probe maneuver. Finally, we do understand that AI is a very new concept and technology, and in anticipation of potential deployment of this AI model that we're going to develop, we are going to do a survey to get the perspective and of an opinion of experts of healthcare workers on the use of AI in clinical practice. So our approach of developing the model is that we will start with getting the images from hospitals and then anonymize these images and extract the cardiac frames of interest, and then label the images. Once that is done, we can then build the model and evaluate it using real-world evidence or real-world data. Now, we have started with existing images from South Africa and Cameroon. These are images that have been stored by expert pediatric cardiologists during routine scanning. And our goal is that we would be able to use these images because it is easy, it's readily available, and does not require time to collect the data. But the problem with these images is that they have been stored by experts, and the experts have only stored the right frames. So, which means that if we use this to train the model, we will not, the model would not know the frames that are not the right frame, in other words, the wrong frame. So the term we use for this is that there's basically no background noise. And so for us to be able to get a background data with the background noise, we would need to collect prospective data. But of course, the problem of collecting prospective data is that it takes time to collect this data. Therefore, we have structured our project to run in two phases. In the first phase, we're going to make use of the existing data to build the initial model framework, and this will involve 500 babies from whom we're going to get 70,000 images. Once the prospective data becomes available, we're going to use this to now update the model, and this will involve 1,000 babies from whom we're going to get 72,000 images. So this is a sort of summary of our project approach. Of course, it is more complex than this, and I hope I've been able to simplify it in a way that it can give you a sense of what we're trying to do in this project. Now, once we have developed the model in this project, what is the next step? Well, we would need to, of course, evaluate this model extensively in various clinical settings. And of course, the model will need to be integrated within the ultrasound systems, and we have to define a way of how the mechanism through which this model or the captured images can be transmitted to the pediatric remote pediatric cardiologists, potentially via existing telemedicine platforms or using our Global Birth Defects app. Now, our current project only focuses on capturing the images. It does not go further to examine these images for any kind of diagnosis. So in the next step, we are going to be developing a model or upgrading the model to be able to examine these images for any potential congenital heart defect diagnosis. Hopefully, this is going to provide additional information to help the pediatric cardiologist to make a better decision. Also, our current project focuses only on postnatal period. So in the future, we would like to look at prenatal diagnosis. And this is very important because obviously if the diagnosis is made early when the baby is still in the womb, it gives a better chance of clinical care and hence survival of the baby. And finally, heat wave is a very important one for us, and we are very keen on looking at how heat wave can impact pregnancy and therefore potential cause of congenital anomalies. So, as you would imagine, we have a lot of areas of interest for collaboration, and top on our list is, of course, getting the images, the echocardiography images, always challenging. Labeling and building the models are areas of potential collaboration. And of course, in the next steps, when if we're successful with this model, it will need to be tested extensively in many different settings, which also is an interesting area for collaboration. And we welcome collaboration on joint grant proposals on the different areas of interest that I have already alluded to. And so if you are an individual researcher, if you belong to an academic institution, research organization, NGO, or civil society, please, we will be very, very happy to collaborate with you. Please get in touch, and we look forward to working with you. Thank you very much for your kind attention, and we look forward to your questions.
Well, thank you very much, Dr. Amaking, for your presentation. And so we'll take questions at the very end of the session. We'd like to move forward with the next presentation. But if you do have some questions for Dr. Amaking, please put them in the chat room, and we will get to them during the Q&A session. If we can load up the next video, that would be appreciated. And this is Dr. Chikowore.
Greetings all, and welcome to the DSI Africa Virtual Networking Meeting. I hope you're all delighted to come and learn more about the projects that we are actually doing in the DSI Africa Consortium. My task is simple. I'm here to introduce you and give you a snapshot of the BCSX Africa project that is focusing on utilizing data science to evaluate applicability of blood cell trait polygenic risk scores for disease prediction in Africa. So the PIs include Professor Segun Fatumo, myself, Dr. Tinashe Chikowore, and Dr. Amu Kama. So to kickstart off, let's look at the background of how we pull we get to the point of constructing these polygenic risk scores. So we rely heavily on genome-wide association studies. So these are genetic studies that are done across our genome, and they get to show us which genetic variants are important for particular traits and by what effect are they associated to the trait, which we then call our weight. So it means that we need these external GWASs to gate those SNPs and also to gate the weights that we then use to construct our polygenic risk scores. But sadly, you'd realize that if you look, this is actually latest information that we accessed in June 2024, just to try to check what is the representations of people of African ancestry in the GWAS catalog. And you'd realize as you look on the map here, that not many parts of Africa are covered here, and the proportion is actually sitting at 0.21%. So this actually shows that we have a very, very low representation of Africans in genome-wide studies. So this then has a very great knock-on effect on how we construct polygenic risk scores, because as you can see on the schematic on the right, we actually realize that prediction accuracy of this polygenic risk scores performs the worst in individuals of African ancestry, largely due to the differences in the allele frequencies, the LD patterns of these genetic variants, basically showing us that we can't rely much on European GWASs. We actually need to have also our own GWASs that can help us, to have more predictive polygenic risk scores on the continent that can work for all of us in Africa. So then to get you more into detail, why are we interested in doing GWASs or polygenic risk scores for blood cell traits? It's because these are intermediary clinical phenotypes. Just to highlight that they're involved in a number of diseases. So we can't ignore blood cell traits, and we know for immunity, we know for cardiovascular diseases. So a majority of the diseases have some aspect that is related to blood cells and all these related traits. So therefore, they are key. They play a pivotal role in us even understanding genetic susceptibility of a myriad of diseases in Africa. But as we have alluded, we're still yet to tap into knowing the precise genetic factors, and we are now eager to use machine learning algorithms to actually find how we can get more predictive or better predictive polygenic risk scores for Africa. So these are our aims in much more detail. So meaning the first aim, we're actually going to discover the genetic variants using GWAS. Aim 2, we're actually going to develop these polygenic risk scores. Then aim 3, we're actually going to see how do they associate with blood cell traits and all these related diseases like diabetes, blood pressure. As we have alluded earlier, that these are actually intermediary phenotypes, so their susceptibility should be associated with multiple traits. So what have we been up to? So currently we are busy working to actually have this very big GWAS of blood cell traits in Africans. So basically on the African continent, we are working to aggregate our GWASs so that we can have about 35,000 participants. Then after that, we're actually going to work with our collaborating partners in various of these large resources also that also have individuals of African ancestry, like the Million Veterans Program, the All of Us project, and also the UK Power Bank. Then we have a very big GWAS that's actually indicative, or much more representative of people of African ancestry. And we then would seek to find key interesting variants, also seek to find better weights that we can actually use in our polygenic risk score. Then currently also looking on the polygenic risk score arena, there's actually a new approach where people are actually utilizing all the polygenic risk scores that have been developed to date. So this is a paper that was released and published where they went into the PGS catalog. So this is where all the polygenic risk scores in majority of the papers are actually deposited. So it when this paper was being written, there were about 2,600 scores. So the idea is, how can we use machine learning so that we build an algorithm so that it can look into all these 2,600 scores and actually show us which ones are important for the trait that we are looking at. And when we know those polygenic scores that are important, then it's actually going to give us the weights in which we need to combine this. So we can actually come from like many polygenic risk scores, then we actually aggregate it into one single polygenic risk score, an approach that we call PRS mix, where we are leveraging machine learning algorithms to mix a number of polygenic risk scores, but only those polygenic risks that are specific for outcome of interest. So this really showed that this approach performs far much better than any other polygenic risk score that has been developed. So as you can see, if it's doing this well, the next question for us is, will it work well in our African context? Why we bear in mind that we know a lot of these polygenic risk scores are trained using European information. If we apply it also to the African context, what can we see? So we then set about, and this project was led by one of our team members, Ruth Nanjala, and she actually proceeded to test this out. And we could actually say that, yeah, indeed, for some traits, there was again an improvement, for instance, the mean platelet volume, but for others, it didn't even help, like aspects as basophils, or a majority of them, hemoglobin, lymphocytes, neutrophils, red blood cells, and the like. But we could see some improvement, like in the mean platelet volume, mean cell hemoglobin, actually showing that, yeah, for some. So it might be that in these traits where it performed well, the genetic factors that actually drive or are responsible for genetic susceptibility might actually be similar. But for those where we actually had minimum or like very, very low performance, like for the basophils, it actually shows that the genetic determinants are different. So this was just preliminary information just to, put our study or the importance of our work in context. That, for a number of traits, regardless of the approach that we use, it might not be the optimal in the African context, and that we actually need local GWASs, then apply these good and more sophisticated machine learning algorithms so that we can get better predictive outcomes. So with these findings, we also have collaborated with our partners like the Wellcome Trust, and also sought, to build or to lift as we rise, to make sure that as we are doing this project, we are also quickly sharing what we are seeing even with many people. So we actually have an annual meeting that we partner with Wellcome Connecting Science about polygenic risk scores, and exactly what we showed you about all these algorithms. We actually gave a project to the trainees to make sure they also upscale, and also they're also working at the cutting edge of polygenic risk scores, so that we can actually have more capacity and more people working in this center, so that we can then now increase the representation of polygenic risk scores. Because indeed, when we have more hands on deck, it's easy to scale up and then to actually increase our presentation. So yeah, we look forward to be continuing with this and equipping many. And we're happy with the mantra that they had after this workshop, where they were saying, if not us, then who? If not now, then when? So now is the time to make sure that Africa is not lagging behind in polygenic approaches, in applying data science techniques to ensure we actually have tools that are beneficial for us as Africans. So in a summary, what are we then looking forward to? So we essentially, I will be pulling this data to ensure as large as Tiwas, apply these machine learning algorithms, and then integrate these and actually see how they are useful for disease prediction in Africa. So thank you so much for coming to learn more about what we're doing, and hope to interact with you further as we listen through our questions and even our future collaborations. And I would like just to acknowledge our team members and also the NIH and Wellcome Trust for their generous support for what we do. Thank you.
Thank you very much, Dr. Chikawore for your presentation. Again, if you have any questions, I'm going to ask that you put them in the chat. We want to make sure that we get through all three presentations. And our next presentation is Professor Mansoor Salah. And I believe you are presenting live. So thank you very much. The floor is yours.
Sure, thank you. We'll share our slides. Sorry, we're just trying to figure out the slides show up and
It's still in presenter mode.
great. Sure. So thank you for inviting me. So I come live from Nairobi at the Aga Khan University Hospital. We'll talk about leveraging AI and machine learning based technology to overcome specialized training and technology barriers for the diagnosis and prognostication of colorectal cancer. The team is seen here. We have the team from AKU. There's a
Sorry
team
to
from
disturb
Tenerife.
you, Prof. You are still in
Yes.
presenter mode. Your document that you are sharing.
Okay.
So if you go to the top, you should say display settings. On your screen, you should see something up on the top that says display settings, and you should change the.
Okay. Connect.
There you go. Press that one.
All right.
There you go.
Sorry. So we have colleagues from Tenerife Hospital up north, about 4 hours away from Nairobi, and our team from the University of Michigan, who are the US partners. Next slide. What we do today, when you give us a pathology slide, is we prepare the tissue, we courier the slides to a third party, they look at the tissue under the microscope, give us a diagnosis, and we treat. That is conventional in Africa because we do not have enough pathologists. Next slide. If you use digital pathology workflow, you still have to prepare the tissue. Rather than sending it to a slide microscope somewhere, you have a digital image uploaded onto a computer somewhere, and there's automatic prognostication and diagnostication, and you treat the patient. Next slide. When we combine automation with AI and machine learning, we do the following. We do image acquisition, send it away into the cloud to some expertise, in our case, the University of Michigan. They will pre-process the digital image, segment the digital image using AI, feature-specific extraction sections from within the H&E image, clustering classification, and based upon the AI, they will say cancer, no cancer. And if you do deep machine learning, we can then diagnose the aggressiveness of the disease. And we have this model already at the University of Michigan, validated for the American population at the VA, and those are our partners. What we try to do is validate the same on an African patient population tissue. Next slide. So in essence, you see on the left-hand side, you have images uploaded, simple H&E, segmentation, clustering. AI does its magic in terms of pixelation, and then will define cancer, no cancer. And if you have prognostic markers already embedded into the AI, it will tell you whether it's a poor prognostic cancer or a good prognostic cancer. So on the right-hand side, you see the pyramid. What we do is part one, operational tasking, scanning, storing the images. What our team in Michigan will do is rescan the images onto their AI model, search the analytic pathway, and then create a diagnostic framework based upon machine learning and AI. And then if we provide them with prognostic tools, the patient's treatment, survival, progression, they can even do prognostication on the model that they provided for us. Next slide. So the aim of our DSI study basically is to adapt and validate an existing ML-based diagnostic algorithm for colorectal cell carcinomas using specific digital fields of view from simple H&E slides. So we have about 700 CRC samples between AKU and Tenerife over the past about 11 years, 2029 to 2021. We use this as our database. What we'd like to do is perform automated pixelation, classification for the colorectal carcinoma features. And then the team at Michigan will confirm that using stepwise, standardized, pre-trained, semi-supervised machine learning technique, and then achieve at least a level of binary result, cancer, no cancer. So that is part one. Part two of our aim is, if we provide them clinical annotation, we will then further develop and refine an unsupervised machine learning method to identify histopathology image-driven measurements specifically associated with the CRC prognosis. So they can only do that if we provide them the clinical annotation in terms of response to therapy, time to progression, etc. So we'll focus on aim number 1. Next slide. So the digital pathway today, as part of the DSI project, is we retrieve tissue from a biorepository over the past 10 years. We do sectioning and simple H&E staining. The pathologist reviews them to be sure that there is tumor on the section and the material on the section is at least microscopically visible. We digitize those and upload them into the cloud. The Viper software on the University of Michigan side will analyze image analysis, provide diagnostic output, cancer, no cancer, and then there's an automated support to be able to say, this patient could be treated this way or the other way. And that is for aim number 1. Next slide. So what have we done over the past year? We began slightly late because of ethical approval, but we have so far, out of the 700 samples we had embedded into our repository, identified about 250, for which we have at least a 5-year follow-up of each patient. So at least we can prognosticate and clinically annotate those individuals. As you can see, usually 60% male, 40% women. And at least in the Kenyan context, we have at least 60% of our patients have rectosigmoid carcinomas. And most of them are adenocarcinomas. The few percent, about 2%, will be small cell variant or other neuroendocrine tumors. But we'll focus on adenocarcinomas. Next slide. This is what we've done in the past 6 months. We started with 2019 because we had, at least at that time, 67 relevant, well-preserved blocks. We sectioned them. 41 of those 67 were eligible because the blocks had tumor. All 41 have been uploaded. We then went to 2017, where we have 61 retrieved samples. We have 46 of those are eligible. Approximately 15 have yet to be reviewed by the pathologist to be sure that we have adequate sample. We've uploaded 38, and we expect to upload all of them who are 46 that are eligible. So in total, we should be having approximately 87 or so samples from 2019 and 2017. Next slide. So in essence, what we've also done is, for the 2019 samples, we've uploaded them onto REDCap and provided all prognostic features: patient age, gender, tumor stage at the time of diagnosis, Ki-67, all the other biomarkers that we would have, as well as treatment, time to recurrence, death or not, etc. So that provides all the information that we can use for aim number 2. We are presenting today, on the 31st of July, our preliminary data. And hopefully, if we have enough information, in fact, the team from the University of Michigan just sent us the download of their information from the first 60 or so slides, but too late to be able to show them to you. Very picturesque digital images to say that it does work when we have cloud computing between us in Nairobi and them at the University of Michigan. We hope to present this data in Mauritius in November at the meeting from the DSI, and we will at that time present preliminary analysis based upon our work currently and the digitization that is done by the University of Michigan team. Next slide. So overall, the short-term impact of this proposal is that we will be able to develop an explainable population-relevant AI ML model specifically for CRC in Kenya, specifically because we have TB, we have HIV, we have a number of other pathologies that may be playing a role in the histopathology of our tumors as compared to those from North America. The long-term impact of this work is the ability to augment the delivery of cancer care in Africa by using AI data science tools for CRC diagnosis and prognostication, because we have in Kenya fewer pathologists than I have at the University of Alabama in Birmingham, where I trained. So clearly, an AI machine learning model would be exactly the way to go for being able to accurately diagnose, but also prognosticate in the future when we may not have the technology or the funding to be able to do specific IHCs on our tumor sections done here. And I believe that was my last slide.
Well, thank you very much for your presentation. So now we'll go into the question and answer period. And so if you have any questions, please put them in chat or raise your hands. And I believe we see Dr. Samson Jarso.
Yeah, that's me. Can you hear me?
Yes.
Yes. That's a really fascinating study. I just wanted to ask rapid fire questions. Of the 87 samples collected in 17 and 19, do you have the full 5-year follow-up for each of them? My question is concerning the genetic diversity of the target population. It seems to me that validating on a very diverse population within the African context will be very difficult. Do you have somehow an assessment of the genetic diversity of your target population? And also of the 87 samples, how many of those samples have significant comorbidities like TB and HIV that are going to really interfere with validation?
Very important questions. So I will answer it in a brief way. For the initial year of half of those samples you saw to my slide, we've already uploaded them onto REDCap. We have gone at least 3 years. Some of our patients have died, and we have information on all patients, half of the first year, first year was 2019, and we have half of the patients on the REDCap. We have full clinical data in terms of treatment, outcomes, relapses, and death. We also have ethnicities. Turns out that the population at Tenwek, which is north of here, is very unique and homogeneous in their ethnic makeup. We get significant proportion of patients from the Nairobi County, which are also ethnically a little bit segregated. About 67% of our patients come from one specific dominant tribe. So we can at least provide that kind of information, and hopefully that will help the team in Michigan to be able to at least dissect through that component. Probably better than in most places in Africa, where you're right, genetic diversity is significant, be it South Africa or somewhere else.
Are you looking to validate 2 models then on the 2 different ethnic groups, or you just don't know yet?
We don't know yet.
Okay.
Yes, we don't know yet, to be fair.
Yeah. Well, it's still very fascinating. Congratulations. Actually, it's really quite amazing.
Thanks.
Yeah.
Thank you for your question. Mandela?
Thank you, Richard. My question also goes to Dr. Mansouri. I mean, you have said that the ethnic constituency is almost more or less similar, but my question is that have you considered any epigenetic variability within this population?
I didn't get the last statement, sorry.
The epigenetic variability.
Oh, no, I think these are all very important questions. We've barely gotten to AIM-1 to say cancer, no cancer. But I think those are important things which allows us to at least extend our observations. But depending upon how many samples we get in the database, depending upon cancer, no cancer, and the prognostic model that we build with the clinical annotation, if that is solid, we can then go to epigenetics as well as the issue about genetic diversity. But those are critical questions that I believe our team from Michigan will be able to answer as we have a stronger database once things are uploaded and reviewed.
So I want to say it's a very impressive work, by the way, and it's very nice. But the other thing that I want to check is, have you compared it with the traditional ways, and have you found any significant improvement with this AI-assisted diagnostic way?
Well, we'll find that out very quickly because we have a very good expert pathologist, so we know the sensitivity and how often we have to get a second opinion. We'll be able to rule cancer, no cancer with at least AIM-1, and at least with AIM-2. If our clinical annotation dovetails very, very well with their deep machine learning, where they can really predict a poor prognostic tumor from a good prognostic tumor, and we can validate that from our clinical data to say this patient died early, that patient died late, that'll be the first step. And then the question is, do we ask more questions? But very much will depend upon how much we upload into the database that we have at the University of Michigan. And the question about HIV, TB, things that really cause significant constraint for us in pathology will have to be tested on this AI model, because the team in Michigan used the VA at Michigan to upload data into their database, and they may certainly not have the kind of comorbid pathologies we have. But all of those will be uploaded in the REDCap, which will be very critical, which is why we selected the time frame of 2009 to 2021 to be able to get enough follow-up on our patients.
Thank you for your question. Aliki, do we have a question in the chat?
So I see a question. Can your AI imaging approach be extended to other tumors? And the answer is specifically yes. You know, in our case, breast cancer, critical, the biggest pathology in Africa. You got in male, it's prostate cancer. The team at US and Michigan had the database specifically in a way aligned and validated on colorectal carcinoma because of Dr. Balaji, who is our principal investigator in Michigan's interest as a GI specialist. So we focus on GI, but I think this machine learning tool should be available to all others, but we will need to have a database on the West validated and that particular tumor, and that'll be the partner that we will have to seek and work with.
Thank you, Doctor. Let's
Yeah. I just want to respond to Oscar's question on liver fibrosis. Obviously, yes, it is very possible to use ultrasound devices. Particularly, you can do ultrasound elastography to diagnose liver fibrosis, and obviously, if we can capture the images, then we can use AI modeling to improve on diagnosis.
Thank you, Dr. Amakeng. And so I see another hand, Letitia.
Thank you. And thank you to Dr. Mansoor for your presentation. Awesome work. Well done. Two things really. What does your telemedicine telehealth regulations say about these type of services in Kenya? And number one. Number two, also, if you wouldn't mind just touching on data privacy. We know we have GDPR in Europe, and all European citizens, wherever they may receive care. In South Africa, where I'm from, is POPIA. So if you wouldn't mind just elaborating on that. Thank you.
I barely forgot the first one, let alone remember the last question. Let me start with the privacy. Since we are embedded with the UZIMA project, we have had significant connections with the federal government here to ensure that we have data privacy. So with our we have a whole team of individuals who have now ensured that what we upload is not only de-identified, but cannot be tracked back, especially when we have genetic information being shared, when we do share specific genetic information on our specific patients. I cannot go into details about that, but that was at least done here, which allows us to go to the UZIMA project, which is much more invasive than what we're doing at the moment. In terms of the adequacy, I think the first thing we'll do is at the end of this year, when we have about 100 samples, cancer, no cancer should be relatively easy, but we need to be sure that it is easy within the context of HIV, TB, etc., the pathology that we have. We'll also go back to see that we've already, as you can see, had 700 samples and only 250 made it so far. So the adequacy of the tissue you store, very critical, and the ability to retrieve blocks after many years is going to be very critical. So part of the question we're going to ask is, in the future, when the AI can do it for you, what is the pre-analytic importance of tissue being stored and fixed and preserved? And those are questions that I think will evolve as we have more data. When we have very good pathology department, if we have only a third of our samples, 700 to 250, being able to be retrieved and quote unquote viable, eligible, it means it doesn't bode well for other places that may not have this expertise. So clearly, new lessons to learn as we complete this project.
Thank you. We have a question in the chat from Helen Merriam. How do you evaluate your model adequacy? It's unclear to who that question was presented to, but I think it's relevant to all three of our speakers, given that all of them are developing machine learning models. So if the three speakers today could really talk about how you evaluate your model adequacy. And we'll start with Dr. Salah.
Well, since I'm an oncologist, the model adequacy, the term may better be responded to by my team in Michigan, who are probably asleep at the moment. However, a number of things is, for us, adequacy is one. Are the samples we stored able to be eligible to be analyzed? Can we upload and the other side receive the same samples via the cloud in a way that they can be digitally extracted? And then the third part is, can we do segmentation on their end based upon the model they've developed on the West? So those are a number of things that we believe so far from the 86 or so we've submitted. And unfortunately, we got 10 slides from Michigan just about 30 minutes ago. I can't show them to you. We've seen that at least by that pathway, tissue retrieval, a third of our samples are lost, uploading very adequate, digitization adequate, extraction very adequate. So far, those things are working well, except for the initial storage that we probably didn't do as well as we would have expected.
Thank you. How about Dr. Amaking? What about how are you evaluating model adequacy?
Yes, just like so I'm not the expert of AI, but my team members, if they could share more light on that. But basically, I guess the first major thing is making sure that we get the right images in that can give us a robust model. In our case, we're making sure that we get not only still images that have been stored by expert echocardiographers, which would just mean that the model will learn to know the right thing and not know the wrong thing. It's also about image quality. Ultrasound devices may vary in different settings, especially the mobile ones that are available. They may have different quality and therefore capture different image quality. And therefore we try to use a diverse set of data captured by different devices and to make sure that the model can learn in all these scenarios so that it can really perform in clinical practice the way it's supposed to perform. But we are also, of course, as part of the process of building the model, making sure that we test it in real patients. So apart from using the train and validation data sets that we splitting the data set into the training and validation data set, we actually as part of this project would be collecting real data from real world patients and then apply the model in this data set to really say that it is doing what it's supposed to do. And obviously, once this is confirmed, there would be a lot of extensive evaluation of the model in real world settings, different settings across Africa, to ensure that the model is doing well.
Thank you. And Dr. Chikwuore, do you have anything to add about your model?
Yes. Just to add to the train of thought and to the discussion, I think also what's important is, especially in our work, I mean, we look a lot into generalizability because, like what I alluded, a lot of the polygenic risk scores are derived from data that is actually European. So generalizability is something that we look into. So there's certain key concepts that we need to factor in. So we'll start finding the polygenic risk score has been trained in Europeans. How does it apply to our African context? So meaning when you're applying our algorithm, we need to make sure that we actually have a testing or a training data set where we actually apply cross-validation. We leave out another data set where we can then also test our model to say, is it generalizable in that? But our ultimate goal then is to ensure that we actually have local or Afrocentric GWASs so that we actually train our polygenic risk scores on African data to predict actually in Africans. As it has actually been shown that prediction improves, polygenic prediction improves when you actually are training from a data set that is genetically closer to your target audience. So to sum it up, I mean, this key issue of ensuring you have cross-validation, you've hold out sample. And in terms of sample size, it's variable. There's no agreement on the actual sample size, but you can actually do simulations to test what is the adequate sample size. Thank you.
So we have about 5 minutes remaining in the session. I know we have one hand up and several questions in the chat, and I'm not sure if we'll be able to get to all the questions. So the one thing that I will ask the presenters to do is to put their contact information into the chat so that if you would like to follow up with them and to discuss potential collaboration and other opportunities, please do reach out to the speakers. And so